Hello friends, I am Dr. Deepak Garg. I am consultant orthopedic surgeon and today we will discuss about the periprosthetic fracture after a total knee replacement surgery. So what is the incidence of periprosthetic fractures after a knee replacement surgery? So if we talk about the distal femur, it is about 0.3 to 5.5%. In tibia, it is 0.3 to 0.5%. And if there is a patella surfacing is done, we will not talk much about patella because I do not usually do patellar resurfacing in my knee replacement surgeries. So it is 0.1 to 2.5%. So distal femur is the most common site of a periprosthetic fracture. So what are the goals of treatment in periprosthetic fracture? Number one, we want to achieve the fracture union. Then we want to have a good range of motion. We want to maintain the limb length and alignment of the knee both in coronal and sagittal plane. And the sagittal alignment should be within 10 degrees and coronal alignment should be within 5 degrees of valgus varus. So this is keeping this goal in mind, we will plan for the revision or the treatment for the periprosthetic fractures. So let's first talk about the classification of the distal femur fracture. So we use a Rorabeck classification for the distal femur fractures. The type 1 is a non-displaced stable implant. Type 2 is a displaced stable implant. Type 3 is a displaced loose implant. So what will we do in type 1, type 2 and type 3? So type 1 is a non-displaced stable implant and the fracture is after the surgery. So what we will do in type 1 is we will try to preserve everything and we will try to immobilize the limb. So we will restrict the weight bearing and then we will apply the cast or the brace and we will wait for the fracture union. So because it is an undisplaced stable implant, most probably it will heal. Now if it is a displaced fracture but the implant is stable, that is type 2, then definitely we will have to fix the fracture, that is open reduction, internal fixation, or sometimes in the distal femur we may use a retrograde intramedullary nail. That is a very reliable method of fixation. Then in type 3 it is a displaced loose implant. When the implant is loose, we will have to revise the implant. So the answer is revision total knee arthroplasty. So similarly, if what are the fixation options? If we are planning for a fixation, what are the fixation options? For example, in type 2, when there is a displaced stable implant, we are planning for the fixation. So we can fix it with a plate, we can fix it with a retrograde intramedullary nail, or we can give a fixed angle plate. So fixed angle plate is also one of the very good option for the fixation of periprosthetic fractures in distal femur. Sometimes we may have to go for the salvage options when there is a severe metaphyseal bone loss, when there is ligament incompetence, or patient is elderly with a low demand. In these type of scenarios, we may have to use the megaprosthesis that we usually use in tumor surgeries. So now let's go on to tibia. Now periprosthetic tibial fractures, we use Mayo's classification and it has 3 parameters. Number 1 is location, number 2 is implant stability, and then the timing of the fracture. Now based on the location, it has 4 types. Type 1 is a tibial plateau fracture. Type 2 is a fracture below the tibial plateau adjacent to the stem, and type 3 is a fracture distal to the implant, and type 4 is a tibial tubercle fracture. Then based on the stability, these are again divided into 1, 2, 3, 4, A or B. Then A is a stable implant, B is a loose implant. Then if the fracture in any scenarios is intraoperative, then it is C. It is given a C, like 1, 2, 3, 4, C. It depends on the fracture timing. So this is Mayo's classification. Now how will we treat these fractures? Based on the location. If the fracture is stable, implant is stable and the non-displaced, again the principle is the same, we can conserve it. We will keep the patient non-weight bearing and we will apply a brace or a cast. Then if the implant is loose, then we will have to change the implant. And if the fracture is intraoperative, then we will prefer using a longer stem and bypass the fracture site in the tibia. And if the fracture is displaced and it is stable implant, then we can go for open reduction, internal fixation of the fractures. Now let's look at the defect management. If there is a bone defect which is less than 5 mm, then we can definitely cover it with a cement. If the defect is 5 to 10 mm, then we may have to use the screws like malleolar screws and we cover it with a cement and manage the defect. If it is more than 10 mm, then we definitely will have to do something about it. We will have to may have to use the metal augments or some other custom made implant, but metal augments work well. We can use the metal augments like the blocks or wedges. Then if it is a type 4, that is a tibial tubercle fracture, then if it is a minimally displaced or undisplaced fracture, then definitely we can conserve it. We may apply a brace or immobilizer. If it is displaced, then we will have to fix it. We may fix it with the wire, we may fix it with the screws or the mesh. If the implant is loose, then we have to will have to revise the implant and do the fixation of the tibial tubercle. Just a slide about the patellar fracture. I don't do patellar resurfacing. If the patellar resurfacing is done and there is a fracture in the patella, then the classification used is Ortiguera and Berry classification. So type 1 is a intact extensor mechanism, type 2 is a extensor mechanism is disrupted, and type 3 is a loose patellar component. In type 1 we can just very well do non-operative treatment. In type 2 we will definitely have to fix the extensor mechanism, and in type 3 we may have to revise it because the component is loose. So if we look at the outcome of the surgeries in periprosthetic fracture, if we use in distal femur, we use a retrograde intramedullary nail, it has a very good results. If we use a plate, it has a good result, and there are chances of non-union also, but it has good results. If we do a non-operative care, then knee may go into stiffness and patient may need a long-term physiotherapy. Patellar fractures, usually the results are not that promising and we may have to face a failure after the surgery. So this was about the management of periprosthetic fracture after a total knee replacement surgery. So thanks for watching guys. For more such educational videos, please like, share and subscribe to our channel. Thank you very much for watching us. Thank you.